Hello, and welcome to the second Pharmacy 15. Again, the goal of these mini lectures is to review the interventional pharmacologic agents that not only enhance the physiologic process being evaluated, but also increase the sensitivity and specificity of the procedure. Oh, and you better know the meaning of those two terms for the boards. This week, we will cover two hepatobiliary medications, simple substitute for one of the medications, and one gastrointestinal imaging interventional medication. Can you guess what that medication is off of the top of your head? I couldn't. The two hepatobiliary medications are morphine and cholecystokinin, or CCK, but I bet you could have figured that out. The substitute for CCK are Ensure or Boost, which really aren't medications, and I'm not sure why the NMTCB lists them on their interventional medications on the components of preparedness. But whatever. The gastrointestinal medications are cimetidine and famotidine. Bet you didn't guess that. So let's start with morphine. Morphine increases smooth muscle tone, particularly the sphincters of the GI and biliary tracts. It contracts the sphincter of Oddi. The back pressure in the common bile duct allows a patent cystic duct to fill the gallbladder with bile and the radiopharmaceutical. This allows the differentiation of chronic cholecystitis or incomplete cystic duct obstruction from acute cholecystitis or complete cystic duct obstruction. If the gallbladder is not visualized 60 minutes after administration of the radiopharmaceutical, the common bile duct and duodenum are present, morphine can be considered. Imaging continues for 30 minutes after morphine administration. An option to morphine for patients with allergies is to wait and do delayed imaging 3 to 4 hours later. Morphine has no use or role in the non-visualized gallbladder in post-cholecystectomy patients. If the duodenum is not visualized, morphine should not be administered. Here are the specific details for morphine. Following intravenous administration, the onset of action is within 5 minutes, with peak activity seen at 20 minutes. The significant effects can last 4 to 5 hours. The standard dose is 0.04 milligrams per kilogram, diluted in 10 mL of saline and given slowly over 2 minutes. The dose range is 2 to 4 milligrams. Do you know what happens if you administer morphine quickly? Some patients vomit copiously. Therapeutic doses of narcotic analgesics should be discontinued for 5 half-lives to avoid interference with the hepatobiliary scan. Morphine is contraindicated in patients with a known allergy to morphine or those with respiratory depression. It should not be used in a comatose patient, and I'm not sure why you would do that anyway. It should be used with caution in patients with seizures, head injuries, asthma, chronic lung disease, hypothyroidism, adrenocortical insufficiency, pheochromocytoma, kidney or liver dysfunction, prostatic hyperplasia, hypertension, shock, inflammatory or obstructive bowel disorders, myasthenia gravis, and pancreatitis. Caution should be used in patients with opioid addiction. While severe reactions with subanalgesic doses in nuclear medicine are uncommon, a number of adverse reactions can occur, which include respiratory depression, dizziness, drowsiness, sedation, nausea, vomiting, constipation, and sweating. The second hepatobiliary medication is cholecystokinin. But before I get too far into discussing this medication, I want to make sure you understand a few definitions. Cholecystokinin, or CCK, is a naturally occurring hormone in the body that stimulates gallbladder contraction and pancreatic enzyme secretion. Cinclide is a synthetic agent that mimics CCK modules. It is an analog. Kinovac is the brand name of synthetic cinclide. Got it? I'll try not to use the names interchangeably. Cholecystokinin is a hormone secreted in the duodenum in response to a fatty meal. It stimulates gallbladder contraction, causes relaxation of the sphincter of Oddi, and stimulates bile production. Cinclide injected into the bloodstream acts directly on the gallbladder. It is used to assess gallbladder function, including the calculation of gallbladder ejection fraction, and to assess patency of the biliary system after gallbladder contraction. During hepatobiliary imaging, if the gallbladder is visualized but no bowel is seen, Syncolite is given to contract the gallbladder so that bowel visualization may occur and gallbladder contractility can be evaluated. Normal gallbladder ejection fraction following Syncolite administration is greater than 38%. Syncolite may also be given before hepatobiliary tracer injection to minimize false positive results in patients who have fasted for longer than 24 hours or who are on hyperalimentation. After IV administration, the onset of action occurs within 5 to 15 minutes, with peak activity seen at 40 minutes. The gallbladder should start emptying within 2 minutes of intravenous administration of Syncolite and completely by 11 minutes. When the gallbladder is seen but bowel is not visualized after 60 minutes of hepatobiliary imaging, 0.02 micrograms per kilogram of Syncolite is infused over 60 minutes and dynamic images are required during that time. Note, some places administer the Syncolite in 10 mLs of saline over 5 minutes, but there's literature to support the slow administration over an hour for effectiveness. If Syncolite is given as pretreatment for patients fasting longer than 24 hours, 0.02 micrograms per kilogram is infused over 30 to 60 minutes. The radiotracer is then injected 15 to 30 minutes after the completion of the Syncolite infusion. Patients should be fasting for a minimum of 4 to 6 hours. Syncolite is contraindicated in patients with known hypersensitivity or patients with intestinal obstruction. It's also contraindicated in pregnant patients because of the risk of spontaneous abortion. Syncolite should not be administered after morphine, as morphine may counteract the effects of the Syncolite, resulting in a false positive low gallbladder ejection fraction. Morphine or other opiates should be stopped for 3 half-lives. Adverse reactions are common but transient and include abdominal pain and nausea. Less commonly, patients may experience dizziness, flushing, the urge to have a bowel movement. Adverse reactions can be minimized by diluting the dose and infusing slowly. Moving on to the third hepatobiliary intervention, we come to ensure or boost, which are the same thing, they just have different manufacturers. And I think this intervention deserves a little explanation. We know from the review of cholecystokinin that the gallbladder contracts in response to fat stimulation. And historically, cholecystokinin analogs such as Syncolite have been used to stimulate gallbladder contraction. However, over the past several years, there have been multiple Syncolite supply shortages, leading to the evaluation of alternative cholecystogogues, or in other words, other agents that cause the gallbladder to discharge bile. One such cholecystogogue is Ensure Plus, manufactured by Abbott Laboratories, or Boost, manufactured by Nestle Health Science. Both are liquid fatty meals that are readily available, inexpensive, well tolerated, and effective in assessing gallbladder ejection fraction. The sensitivity and specificity for the detection of chronic cholecystitis is similar to that of CCK. The normal ejection fraction for Ensure or Boost is greater than 33% after 60 minutes. The Ensure or Boost imaging protocol is 60 minutes of Syncolite. A 60-minute pre-Ensure Boost dynamic study is performed. Static left anterior and right lateral views are obtained to confirm gallbladder radiopharmaceutical visualization. The patient is then given 237 mLs or 8 ounces of Ensure Plus or Boost to drink. Ideally, the patient should drink the entire amount over 5 minutes, and an additional 60-minute dynamic study is acquired. The precautions for Ensure Plus and Boost predominantly involve allergic reactions. Patients with lactose intolerance generally do not have problems with Ensure Boost Plus or Boost because of the low amount of lactose in the formula. Patients with galactosemia, a rare hereditary disorder affecting how the body processes galactose, should avoid Ensure Plus and Boost. Note, galactose is just a simple sugar found in milk, dairy products, grains, and other plants. Adverse effects can include nausea, vomiting, and diarrhea if too much is consumed or is consumed too quickly. Ensure and boost, as oral agents may not be suitable for patients who cannot tolerate oral intake. Finally, we come to cimetidine with the brand name of Tagamet and famotidine, also known as Pepsid, which are used in Meckel's diverticulum imaging. There is another drug, ranitidine, or Zantac, which can be used, but for some reason it's not on the NMTCB's components of preparedness list. The gastric mucosa concentrates technetium-99m per technetate. This includes the mucosa in Meckel's diverticula. Cimetidine and famotidine are H2 histamine receptor antagonists, or H2 blockers. These agents are used to reduce the amount of stomach acid produced. The detection of a Meckel's diverticulum can be enhanced by either increasing the uptake at the site or reducing migration away from the site. While pertechnetate accumulation is not affected, the change in gastric acidity in response to cimetidine famotidine reduces secretions in the gastric lumen, concentrating the radiopharmaceutical and thus enhancing visualization. Cimetidine is given orally and has an onset of action of 30 to 60 minutes, with peak activity seen at 60 minutes if taken on an empty stomach and 120 minutes if it's taken with food. The effects last 4 to 6 hours. The onset of action for famotidine is 60 minutes, with peak effect reached 1 to 3 hours, and the duration of action 10 to 12 hours. For children, the cimetidine dose is 20 milligrams per kilogram per day by mouth for 2 days prior to the scan. Then, on the day of scanning, 1 hour before imaging, 20 milligrams per kilogram is given IV and 20 mLs of saline over 2 minutes. For adults, 30 milligrams by mouth 4 times per day for 2 days is given, with imaging performed within 60 to 90 minutes of the last dose. For famotidine, 0.5 milligrams per kilogram per day is given orally for 2 days for children, and 20 to 40 milligrams is given orally for adults. Both of these drugs are well tolerated and have good safety profiles. As always, the medications are contraindicated in patients with a known hypersensitivity. Adverse reactions include dizziness, confusion, headache, diarrhea, and bradycardia. So there you have it. You've completed the second Pharmacy 15 on hepatobiliary and gastrointestinal medications. I discussed morphine, which increases smooth muscle tone and contracts the sphincter of Oddi, aiding in gallbladder visualization and differentiating types of cholecystitis. I discussed cholecystokinin, or its analog Syncolide, which stimulates gallbladder contraction and bile production and assesses gallbladder function. An alternative to CCK analogs discussed are Ensure or Boost, which are liquid fatty meals that stimulate gallbladder contraction. Finally, we covered cimetidine and famotidine, which are H2 histamine receptor antagonists, reduce stomach acid production, and are used to enhance the detection of Meckel's diverticulum. Each of these medications has specific uses, dosages, contraindications, and potential adverse reactions that you should be familiar with. Don't forget that on Moodle, there's a summary document of these slides and a template for you to create flashcards to help you study. Keep studying, and please reach out if you have any questions.